So hello guys, this is Dr.Ajinkya here and welcome back to my channel. So today I'll be discussing something called as the orbital septum. Now this orbital septum is really important. So we have a 3D model over here. So I'll be talking about the detailed anatomy of the orbital septum, its relation to the orbital contents and its clinical significance, that why you should know about the orbital septum. So before I do that, I want to show you that if you visit my YouTube channel and if you want to become a member on my channel, you can just go to your browser or the YouTube app and my homepage, and you can see a button over here which says join. You can just click on the join button and you can get a monthly subscription pack. And what you're going to do is that you're going to get access to all my surgical videos, which are members only videos, in which I have explained in detail a lot about the sinus and skull base surgeries in each and every step to make it very easy for the new residents and those who are learning ENT and sinus skull base surgeries out there. Also, I have a lot of specific skull base theory lectures of how you can access different skull base surgery routes and get your concepts really clear. And also, if you have any doubts or queries about anything, any academic doubts or any surgical doubts, you can leave me a message on my Facebook profile. Now that's my profile. I'll be surely happy to reply back to your queries for sure. So coming back to my topic over here is the orbital septum. First things first is the anatomy of the orbital septum. Now what exactly is the orbital septum? It is actually a thin fibrous membrane. Okay, you can see whatever structure you can see. This is the orbit, that's the bony orbit, and inside what you can see is the whitish structure. This thin whitish structure over here, that is the orbital septum. So orbital septum is a thin fibrous structure which is an extension or a reflection of the periosteum of the orbit, and which extends from the superior margin and the inferior margin respectively, like this, as you can see in the 3D model over here, and then goes on to attach itself on the superior and the inferior tarsal plate respectively. On its way above in the superior region, it goes through the aponeurosis of the levator palpebrae superioris meshwork, as you can see in the 3D model right here. So this is actually the orientation of the orbital septum. Now orbital septum is like really thin and plays an important role in preventing the entry of the infections from the anterior contents of the orbit. You can say exactly the eyelids and the orbicularis oculi muscle and area from external sources. It prevents the entry of the infection into the intraorbital contents, which is nothing but the periorbita, the periorbital fat, the globe, the extraocular muscles, the optic nerve, and the intracorneal compartment. So that's the intraorbital contents. So it prevents any entry of the infection into that orbital space. So that's the prime role of the orbital septum. Now, what are the conditions where the orbital septum fails, to prevent the entry of the infection? Now, the 3D model is in front of you. You can actually see that these two structures you can see over here, which resembles the eyelids, is actually the tarsal plate, and it gets attached to the tarsal plates. So it is nothing but extending from the orbit, the bony orbit, and up to the tarsal plates above and below in both sides. And also it is oriented in the lateral and the medial direction as well. So you can have a live orientation of how the orbital septum is actually oriented to the nasolacrimal duct system as well as the medial orbit, the medial palpebral, and the lateral palpebral ligament over here. So the palpebral ligaments are actually anterior to the orbital septum. Also, the orbital septum is kind of lateral to the nasolacrimal duct system as a whole, and it somehow attaches to the posterior lacrimal crest as well. So this is how the orientation of the orbital septum is actually. And if I can see over here, the levator palpebrae superioris is actually within the meshwork of the orbital septum. It pierces through the orbital septum and has its attachment on the tarsal plate over here. So as you can see, any external forces, the mouse of the cursor being any external forces, infection, if they try to enter into the orbital cavity over here behind, this orbital septum is going to act as a barrier. So that's first function, it acts as an anatomical barrier. The second thing is that you need to understand is how you can differentiate a patient from a pre-septal cellulitis to a post-septal cellulitis. Now, the basic concept lies in this fact that anything which is anterior, this is the orbital septum, anything which is anterior to the orbital septum is considered to be as pre-septal, and anything over here which is considered posterior to the orbital septum is considered to be as the intraorbital, or you can say post-septal, which is nothing but the orbit, the intraorbital basically. So on the basis of that, if a patient presents to you in the ophthalmic OPD or an ENT OPD, because a patient may have, the origin could be from the ethmoid sinusitis, because most commonly infection into the orbit enters from the ethmoid sinuses. So if the patient has got ethmoid sinusitis, chronic ethmoid sinusitis, the patient's infection route of entry may be through Zucker candle deficiency or many other natural deficiencies in the bony orbit and the ethmoidal partition. So this is how the infection may spread. So the patient may present with swollen eyelids and erythema all over the eyelids, and the patient may have painful eye, but the patient is able to move the eyeball in all directions. Also, the vision is not lost, the vision is completely intact. That means the patient is having a pre-septal cellulitis. Mostly it could be because of an external trauma, any foreign body indulgement, or any infection, gram-positive infections like that. So that is one point symptomatically you can differentiate. The second thing is the patient, if has vision loss or there is extra ocular muscle involvement, the patient is not able to move the muscles or to move the eyeball in particular direction, it means the patient is having an intraorbital component, and that means the patient is having infection posteriorly, that is post-septal cellulitis. Sometimes the patient may have long-standing ethmoidal sinusitis. There could be a breach in the lamina papyracea. Now, I need to show you the lamina papyracea exactly. Now, this is a posterior lateral view of the patient's left orbital cavity. You can see this is the lacrimal bone over here, and this is the ethmoidal bone. This ethmoidal bone is nothing but the lamina papyracea, which acts as the medial orbital wall, and you can see the anterior and the posterior ethmoidal cavities over here, through which the anterior and the posterior ethmoidal cavities are the canals in which the anterior and the posterior ethmoidal nerve runs along. So these could be the deficiencies from which the infection may enter, and that's the most thinnest lamina papyracea. If there's a deficiency in that, the infection could enter into the orbital cavity and may cause post-septal cellulitis. So this is how you need to differentiate the pre and the post-septal, for which you need to have the anatomy of the orbital septum very clear. So this is so far the basic anatomy. The various organisms which can involve the orbital cellulitis is the gram-positive Staph aureus, Streptococcus, Haemophilus influenzae. If there is a fungus involvement, in case of the case where the fungal involvement is there in cases of immunodeficient individuals, invasive or allergic fungal sinusitis may have an impact on the orbit. So it may cause orbital compression, optic nerve compression, and may result in loss of vision, for which an orbital decompression will be necessary. So the orbital septum, the origin, the position, and the orientation of the orbital septum to all these structures should be clear. So also there's a theory that the orbital septum is present above and below, and the upper and the lower eyelid has got two lamellar regions, the anterior lamella and the posterior lamella, in between which we can see the orbital septum in the eyelid. So in the upper eyelid, if there's the anterior lamella, which consists of the skin of the eyelid and the orbicularis oculi, in both the upper and the lower eyelids, it's going to be common. It is made up of the orbicularis oculi muscle and the skin of the eyelid. That's the anterior lamella of the upper and the lower eyelid. When it comes to the posterior lamella, the upper eyelid consists of the levator palpebrae superioris, aponeurosis, as you can see over here, then the Mueller's muscle, then the conjunctiva in the most posterior aspect. Okay, and that's the anterior lamella, and then you're gonna have the inferior eyelid, in which the levator palpebrae superioris muscle won't be there, but instead of that there will be presence of capsulo palpebral membrane, capsular palpebral ligament, in which is a counterpart of the levator aponeurosis. So along with that, the conjunctiva should be there. Okay, so this is the anterior and the posterior lamella of the upper and the lower eyelid respectively, and between which you can see the orbital septum. So it prevents the entry of the infection into the main intraorbital contents. So that is all about the orbital septum, and this is how it is oriented to the nasolacrimal duct and the medial and the lateral palpebral ligaments over there. So this is how also you differentiate the preseptal and the postseptal, the treatment of which is nothing but you refer the patient to an ENT or a skull-based surgeon for clearance of the ethmoidal sinusitis completely, and start the patient on IV antibiotics and symptomatic treatment for sure. So also we need to remember, if the patient is having a proptosis, anterior projection of the eyeball, chemosis, red swollen eye with painful movement of the eyeballs and restricted ocular movements, there should be a lot of differential diagnosis such as the rhabdomyosarcoma, lymphangiosarcoma, and retrobulbar fat prolapse, and other different conditions like that. So it could be the infection, it could be secondary to ethmoidal sinusitis and stuff like that. So a lot of differential diagnosis exists for the ophthalmic surgeons to differentiate the swollen eyeball and the swollen eyelids. So this is all about the orbital septum. And last point I need to tell you that the midface, the anterior 1/3 of the midface always drains into the pterygoid venous plexus, and that occurs through the valveless ophthalmic veins. Now, a lot of structures, a lot of nerves and vessels pierce the orbital septum, and a lot of ophthalmic veins, they pierce through and go towards the pterygoid venous plexus for drainage, which is posteriorly also it drains into the cavernous sinus eventually. So a lot of infection, a lot of times any infection in the face may lead to the infection into the orbit if it enters into the ophthalmic veins. So the orbital septum plays a role as a mechanical barrier for the entry of the infection so far. But if at all, if the orbital septum gets damaged or has a lot of deficiencies in it, there may be spread of the infection, for which you have to start the antibiotic treatment and symptomatic treatment as well. So I hope the concept of the orbital septum, the orientation, is a lot clearer now. And if at all you think I have missed out on certain points, or I should have added more points in this lecture, please you can leave a message in the comment section below, and I'll be free to highlight that comment to the world outside. So I think that's it for today's lecture. Maybe I'll see you in the next one, and in the next lecture for ophthalmic surgeons, I'm going to teach the lecture about the orbital apex syndrome, the cavernous sinus thrombosis, and superior orbital fissure syndrome, and also what are the points where you can differentiate all these three from each other. So I'm going to show clinical photographs and easy points to remember which condition we have which specific signs and symptoms. So I think I'll see you next time. Till then, take care, guys.